Okay, looks like it's time to get started. Just want to welcome everybody. So glad you could be with us today. Steve and I were just talking about some New Year's resolutions. At least I was sharing with him some of mine, and so yeah, I'm hoping you're all doing well and feeling good, and hopefully feeling like the year is getting off to a good start. So thank you so much for joining us and being with us here. This is the Essential Substance Abuse webinar series, and this is offered by the National American Indian and Alaska Native Addiction Technical Transfer Center. And I'm Kate Trams, and Steve Steiny will be presenting on referral, service coordination, and documentation. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We're part of the ATTC network, which also includes 10 regional centers, 5 international centers, a network coordinating office, and the National Hispanic and Latino ATTC. In the next couple of days, we will send out a follow-up email to everyone who attended. It'll include a link of the recording, handouts of the slides, and a CEU request form. We are a NADAC certified educational provider, and we can provide CEUs for a $15 fee. I'll just note too that often all you need for your certification renewal or something is the confirmation that you attended, and that actually comes in the email we automatically send out. So that may suffice for what you need for your certification. Immediately following today's webinar, you will be redirected to our GIPRA evaluation. This survey just takes a few minutes to complete and asks about your satisfaction. This feedback is critical to our future work, and we value your opinion, and we would greatly appreciate your time in sharing your thoughts with us. You will be muted for the duration of this webinar, so you can use the chat pod to share your questions and comments. You also could, if you wanted to, enable your webcam, and then Steve and I can see some of your faces, and that's just like a nice way to have a little bit more interaction and everything. So you can do that if you would like to. But you can also please share questions and comments in the chat pod, and we'll address those at appropriate points during the presentation. Today's speaker, as I mentioned, is Steve Steiny. Steve is our program manager for the Addiction Technology Transfer Center, and he has been an alcohol and drug counselor since 1997. He has worked in the behavioral health services and nonprofit sector for the last 23 years and has been in recovery for over 31 years. And he's committed his life and profession to helping others in the recovery process. So I just want to thank Steve so much for presenting for us today, and I am going to pass things over to him. Thank you, Steve.
Thanks, Kate. Can everyone hear me okay? Kate, am I coming through okay to you?
Yep, I can hear you really well, Steve. So
good.
Please let us know in the chat pod if you have any problems hearing anybody.
Yeah, I'm utilizing the headphones today in hopes that my voice will be picked up a little bit better. So good morning or afternoon or whatever time of day it finds you in wherever you're at today. I'm here at the National American Indian Alaska Native Addiction Technology Transfer Center, Native Center for Behavioral Health here in Iowa City, coming to you live from the College of Public Health at the University of Iowa. So I'm honored to be here today, and let's see, Julie's saying you're low in sound. Julie, I'm going to try, and I'll try and project the best I can, and hopefully you can pick that up. You might just try cranking up your volume as far as it'll go. Oh, good. Julie's saying it's better now. So, just want to welcome you all to today's presentation. I want to wish you all the best as far as Happy New Year goes. I know in Western culture it's sort of connected to the calendar, but I've also learned and am learning about Native New Year's sometimes are more connected to springtime and other seasonal signs of the rebirth of the year. I was talking to a tribal member in the Winnebago area, and she said that the new year for them does not start until first thunder. So I like that idea. It makes sense to me. So this morning, I think what we're going to try and do is, or I guess it's afternoon now, so I think this afternoon what we'll try and do is go through the slides. We've just completed, the last 3 months, we've talked about evaluation of the different components connected to that. We're going to shift gears a little bit now and talk about communication between referral sources and also documenting this kind of referral process, really to benefit the patient and also to benefit your respective agency. I'll assume that many of you are working in the behavioral health field and then also working primarily with Native populations. And I'm obviously not Native, but I do and have been working closely with our center here, and have had a chance to begin my cultural awakening and my learning process, learning a lot about Native culture and how it applies to the behavioral health field. So I'm hoping to learn some from all of you today. But I think we should go ahead and get started. Before we do, I just wanted to take a couple of minutes to just kind of center ourselves with just a short prayer. So let's do that here, and then we'll get started. Father of light, Mother of earth, creator of all, stay with us today as we move through this presentation. Help keep our minds and hearts open to learning and sharing and collaborating. And I would hope that you would stay with us throughout the day, guide us and protect us now and moving forward, us and all of our relatives. Thank you. I'm also fighting a head cold, so my voice is a little off. Everybody say a quick prayer for me that my voice holds up during this presentation this morning. And I'm hoping the slides we have today are not quite as extensive, so we may have some time at the end to have a dialogue as best we can using the chat box. So I think without further ado, let's try and move through some of the slides and have a discussion. So our goals and objectives for today really are to take a good look at the referral process. And I know, having worked at the clinic for many years, both receiving and providing referrals, absolutely essential to good continuity of patient care, and absolutely essential to establishing, building, and maintaining those relationships between agencies and colleagues and those in the field. So we're really I'm going to try and return to that point as we go through. Also, just talking about service coordination, we'll talk a little bit about the ROSC sort of model, the recovery-oriented service care model, and talk about importance to documentation. I know documentation can be, at least for me, it was always sort of that thorn in my side, but I think now with a lot of the electronic health record systems, the shift is happening to where it shouldn't be as much a burden, but we know documentation is key for patient advocacy. It's also important just for ethical and professional reasons to have your work documented so that you can protect yourself, your agency, and of course the patient. And we'll talk a little bit about case management, probably not as much as we should, but at least looking at case management as a vital tool and resource to provide continuity of care and quality of care to the patients that we serve. And then we'll also touch a little bit on research. There's some of the research that's out there. So let's start moving through. So one of the things we can look at and kind of keep in mind as we go is this recovery-oriented service of care response. So thinking about a patient's recovery along this continuum, that there really is not an end point, that it really continues throughout the duration of their recovery. Whether or not you're directly involved in that may or may not be the case, but you can also see that the patient's symptoms and their severities, in other words, how they're responding to treatment, or whether they have some challenges, some slip-ups or setbacks. It doesn't mean that the promotion of self-care and treatment services or the rehabilitation support, recovery support changes. So this model just demonstrates this idea that the promotion and continued support of recovery continues throughout the person's recovery. There's a continuous treatment response. Hope that makes sense to everybody. And this theme will kind of follow us throughout today's presentation. And then just looking at this very, this is a very rich and very extensive overview of this ROSC sort of model. So really we see in the center, we see the individual, family, and community as sort of the nexus of this, and then circling outward the different layers of support that take place. And these supports, at least in theory, would work collaboratively with one another to promote all of those three sort of primary goals in each of the areas of wellness, health, and recovery. So these services and supports centered around the individual, the identified patient, the family, and the community in which they live would really be the anchor points are recovery, wellness, and health. So I hope that makes sense, but ROSC offers this comprehensive menu of services and supports that can be combined and adjusted to that patient's needs and whatever their pathway to recovery may be. It's very adaptable. It doesn't have to be centered only in a specific modality for recovery. It can be applied to any number of recovery pathways. Hope that makes sense. So let's just define, or at least as a group, if we were all meeting together now in a face-to-face setting, I would ask for us to come up with kind of a group definition. But if any of you want to add to this definition as we go, feel free to jump into the chat box and add some pieces to this. But a referral is the process of facilitating the patient's utilization of available support systems and community resources to meet the needs identified in the clinical, that evaluation setting, or in the treatment planning aspect of the patient's care. So we're going to really think about this as if you're making a referral, it really is about communicating effectively to that referral source and letting them know the patient's needs, the patient's strengths, and the patient's goals moving forward. And this will change, and there'll be different levels of complexity depending on the nature of the referral and the chronicity of the patient's illness or their severity of their substance use disorder or other related comorbid concerns. Again, this is really establishing and maintaining relations with all of these things listed here. And I think the key word for me in this is the relationship, or the relations, because having worked in the clinic for many years, one of the things that I really valued was having that connection and understanding with my referral sources, and vice versa. They knew me by first name oftentimes, and we had successfully made referrals with one another mutually, and oftentimes had very, very good understanding of one another's services. So But establishing these relationships can take time, but it can be connected to any one of these areas that's listed on the list of the referral relations. Again, being able to communicate effectively with your referrals, continuously assessing and evaluating referral sources to determine their appropriateness. So, agencies change, staff changes. I need to be, at least in theory and in best practice, aware of, so if I call up and say, hey, I'm making a referral, I need to speak with Janet, and they say, well, Janet is no longer here, then I know for myself that I may need to step back and, reassess and rebuild a relationship at that agency with a new staff person. I don't know if anybody else experiences this, but we know turnover happens, and sometimes it can be difficult when someone you've worked with for a while in the field is no longer at an agency. But establishing that relationship, that collaborative relationship with these key contacts in your area. All right, Richard, thanks for joining us. Interpreting and using evaluation of patient feedback information, so referral data that we get, and then giving feedback to community resources regarding their service delivery. So I want to be able to make a referral or say to my patient or my patient's family, I'm referring you to this psychiatrist. He or she is very good. I've worked with them in the past. They specialize in this specific area. I think you're really going to benefit from following through with this referral. That's just to be one example. Also, just differentiating between situations in which is most appropriate for the patient to self-refer to a resource and instances requiring counselor referral. So I could make a referral to the domestic violence shelter and really leave it up to the patient to initiate and follow through with that. Whereas making a referral for a mental health evaluation or a formal physical exam might be something that I would be much more involved in. But interpreting assessment and treatment planning materials, assessing the patient's readiness, so that's important too. That will dictate and really sometimes alter the types of referrals you're making depending on how ready the patient is. But assessing the patient's readiness and being able to kind of roll with that instead of forcing a referral or mandating a referral. Now, don't get me wrong. There are sometimes cases where the mandated referral is part of perhaps their probation or parole agreement or something connected to Department of Human Services or some other entity outside of them. But in cases of self-referrals, that certainly, I would certainly gauge the patient's readiness to change in a different light. And then educating the patient regarding appropriate referral processes. So being able to say, here's how it works, and it's important that you do this, this, and this if you want to be able to connect with this referral source in the community. Also, just arranging referrals to other professionals, agencies, community programs, or other appropriate resources. And then explain in clear and specific language the necessity for the process of a referral. Remember, not only does this help ensure that patient follow through, but I think it's really important to let the patient know the more I involve them in this process, the more likely they are to attach meaning and purpose and invest in this referral. So it wouldn't be uncommon for me, say, to make the referral with the patient in my office together. We might make a call together at the time of our session and speak with the referral source on a speaker or conference call setting and make sure that we're all on the same page. And we're going to talk about, making sure we have the written consent to do this and some of those other logistical pieces in place, but making sure you involve the patient in the decision and the reasoning and what they can expect. This will help, at least from my experience, ensure there's better follow-through on the part of the patient or the patient's family. Hope that makes sense to everybody. Joanne, I'm glad you made it, and I'm glad to see you got your audio working. Hopefully everybody can still hear me. My voice seems to be holding up, so and I haven't coughed yet either. So you guys, I think your prayers may be working, so I want to thank you all for that. Let's look at a couple other components of the referral process. Just the exchange of relevant information with the agency that I'm making the referral to. Sometimes less is more, but I need to make sure that the information I send is applicable and concise and is going to really best represent the patient's needs. And then also just to evaluate the outcome of the referral. And this can come in the form of following up. Oh, there's a cough. Sorry. I tried to mute that, so hopefully you guys aren't getting coughed right out of the webinar here. I'm sorry. Following up, I think, is really important. It's a responsibility to contact that agency post-referral and then check with the patient to see if they were able to engage in the services that you did refer. And again, I think these are, pretty straightforward, but, number 8 certainly, I would say is best practice courtesy, and your patient's health and well-being may depend on this. If you have obtained proper ROIs and make the call and or send a follow-up letter, this can really have an impact on how you respond to the patient post-discharge or post-primary care. And then lastly, number 9 too, I think just following up with the patient is also important. It may provide an opportunity to further ensure that they're getting the care they need. And this was often a time too where I could check in with the patient just to let them know that I'm thinking about them and pulling for them. And that sometimes can really have an impact if they're to return to your agency for future services. Let's talk a little bit about, does anyone have any questions so far? Anybody want to chime in or have a question that I could field before we go? Let my voice rest for a minute here and maybe see if anybody has any questions. See, Richard's typing something here. We have till about 1:30, so I think we're doing okay time-wise. Kate will kind of keep an eye on that for me, too. Richard may be typing, maybe he types like I do, just sort of one key strike at a time. Well, let's keep going. I'll see if maybe a question pops up. Maybe Kate can. Oh, here we go. Good. Okay, Richard. Thank you. Great. That's great. Okay. Well, let's keep moving now. Let's keep pushing forward. And again, feel free to jump in with a question, and I can try and field that as we go. Or we'll have some time, hopefully, at the end to have a dialogue via the chat board. Just let's talk about service coordination. I think this. Again, is extremely important. This I found interesting. This is from Dennis Banks of the Ojibwe and the founder of AIM. Just a quote from him. Since the beginning, Native people lived a life of being in harmony with all that surrounds us. It is a belief that all humankind are related to each other. We believe we are related to all other living species, the winged ones, the four-legged ones, the plant life, and the elements of life, air, fire, water. The sun, the moon, the stars are there to guide us. I thought that connected well with this idea of coordinating with those around us, especially in a smaller community, how important that is. Service coordination from sort of a Western standpoint or kind of a Western definition, and again, I think if we were here as a group face-to-face, we might brainstorm a bit and talk about what this means to all of you. but I think for the purposes of the webinar, let's call service coordination the administrative, clinical, and evaluative activities that bring the patient, treatment services, community agencies, and other resources together, and really help focus these and help us focus on what the needs are, what the issues are, how they're reflected in the treatment plan, and how we can collaborate and help this process through, and really be guided by the patient and what their needs are, and what they're verbalizing or what they're showing us they need. Service coordination, this really includes case management and patient advocacy, and I think it's important to understand, going back to when we talked earlier about establishing those relationships, it's a framework of action for the patient to achieve specified goals. Now, this young man, I think, has been involved in the picture here is involved. It looks like he's been involved in a fishing accident. He's got, like, he may still have something stuck in his lip there. I'm not sure. Somebody may need to call him, Kate, and make sure he's okay. All right. Hopefully somebody's laughing out there. That was my one attempt at humor. I don't know if I'm off on the wrong foot maybe already, starting in 2020. Let's look at service coordination again. Hi, Maria. It's good to see you. Service coordination, let's talk a little bit more. It involves collaboration with the patient and the significant others. And this can be the relatives, or in a broader context, this notion of tios. Let's see if I get this right, if I can pronounce this. Tioshapa or tioshaye. But this idea of family, or this idea of one's relatives. I know in Lakota culture, this can be up to 150 members. But involving family and significant others or relatives in this coordination process. Coordination of treatment and referral sources, and then involving liaisons. There may be a school liaison, there may be a court-appointed liaison, and then really utilizing this coordination for ongoing evaluation of progress and ongoing evaluation of needs. Service coordination includes implementing the treatment plan. And I know sometimes, depending on the context, this may or may not go smoothly, but if the treatment plan is, and if you've joined our previous webinars in the past months, we know that the treatment plan is often a living document. In other words, it changes, it ebbs and flows depending on the patient's progress, lack thereof, or their needs at the time. So utilizing the treatment plan in the referral, especially if it's a step down from one level of care to the other, or an agency referral from the same level of care to another agency's same level of care, that treatment plan can be a vital key and guide, not only for the patient to say, here are my goals, but for you to advocate for the patient and say, here's what we've been working on, and we want you to have this so that you can continue this work. But just to initiate collaboration with the referral source, obtain and review and interpret all relative screening, assessment, initial treatment planning information. So this works in the reverse too. If I receive a referral from another agency and it includes a treatment plan, it's absolutely important that I review that and make sure that we are addressing those goals and involving the patient in that discussion from the very beginning, if it's a new patient that's been referred especially. And then complete any necessary administrative procedures to have that patient admitted and engaged in services. Implementing the treatment plans. This sort of continuing this idea. This really helps establish accurate treatment and recovery expectations within the patient and any other family members involved. It can be a dialogue, and it can be really important that the treatment plan goals and expectations in their recovery are documented in the form of a comprehensive treatment plan or a healing plan of some kind, as they are either referred or received as a referral. Again, implementing the treatment plan, this idea, being able to develop and maintain kind of a community referral list to help plug in and see where community resources can be utilized to help meet some of the treatment goals. Develop a multidisciplinary collaboration within the community. I think is also, it can be tricky, but if you have some established relationships, you're able to really know where those resources are and how to connect the patient with those. Deliver case presentations, use appropriate technology to collect and interpret patient treatment information for diverse sources. Also looking at just demonstrating accurate, clear, and concise verbal and written communication. Other things to keep in mind, just be part of this interdisciplinary team. This will help address goals that may be outside of the scope of your practice specifically. But if you have somebody that specializes, say, in HIV or STD testing, part of your either medical team or perhaps a psychiatrist or mental health provider that would be able to address mental health concerns reflected in the treatment planning. Participate in negotiation, advocacy, and resolution of conflict, and problem solving and mediation. The treatment plan can be utilized as a bridge in that area. And assist patient in developing, maintaining contact face-to-face, telephone or electronic mediums to do that. And then just documenting progress or changes to the healing plan or the treatment plan itself. Let's look at service coordination. This would include, consulting. I think consulting is often underrated and underappreciated. The consulting really allows for the summarization of the patient's personal and cultural background, treatment plan, recovery process, and any problems inhibiting or blocking or barriers that are preventing progress. Understanding terminology, procedures, and roles of other disciplines related to the treatment of substance use disorders. And again, I think this, if I have a patient who has a myriad of co-occurring or comorbid issues that really may be the real underlying factors, I need to be able to understand what that means and what services I can assist the patient in coordinating. Remember, folks, and I think most of you would agree with me, and it's okay if you don't, but in the substance use treatment disorder field, it's very clear to me that the patient's substance use is not the problem. The patient's substance use is not the problem. It's causing them problems, don't get me wrong, but it really is a symptom. It's an underlying, or it's a symptom or an indication of some underlying issues. And we could list off a myriad of those that might be connected to that. But I hope that concept makes sense. A patient's substance use or alcohol use is not the problem. It is a symptom. So I wanted to reiterate that. I usually mention that in the beginning of the presentation, but also just coordination may include being able to contribute as part of this multidisciplinary team. So you may come in and specifically speak to a specific type of substance use or a specific component of substance use disorders, or wherever your area of expertise lies, where your credentialing lies, or where your clinical expertise lies. And then just also, it's really important when coordinating services that you apply all confidentiality rules. I know we're all familiar with 42 CFR Part 2 and some of the other HIPAA regulations that really govern and serve to protect patient records, especially when it comes to substance use disorders, because we all know, I think, and I think I can again safely assume that we know that there's still a pretty significant stigma attached to those seeking services for alcohol or drug use disorders or mental health disorders. Let's continue to look here at service coordination. This includes continuing assessment and treatment planning. So when coordinating services, you maintain ongoing contact with the patient and involve significant others. It may involve understanding and recognizing the stages of change and other signs that the patient is making progress, whether it's utilizing some clinical measurements or utilizing specific program measurements that are built into your curriculum, and then making appropriate changes to the treatment plan to make sure that progress towards treatment goals are happening. That you can document this, whether there's setbacks or adaptations or amendments to this healing plan, but really being able to measure and with the patient's involvement that they are making progress. Describe and document treatment process, progress, and outcome. Again, being able to say, this is what the patient and I are working on, and here's evidence of that. Not only does that give the patient the ability to prove the work that they're doing, but it also protects you as the clinician to document and show that you are billing for or providing the services that you say you're providing. Again, looking at this continuing assessment and treatment planning process, I want us to keep in mind and sort of overlay the stages of change concept. And the stages of change have been around for a while now and have been woven into quite a few different treatment approaches. So if you're not familiar with the stages of change, feel free to email me or talk to your colleagues there. I can get you a lot of information on stages of change, but it's important to keep the stages of change in mind as we're continually assessing and developing or maintaining the healing plan goals. A patient's readiness to change can evolve during the treatment process or devolve, as the case may be in certain situations. But understanding that assessing and making treatment planning or healing plan strategies will really be contingent upon how ready the patient is to make changes in their life. And in this case, I think specifically in the context of substance use disorders. But just using accepted treatment outcome measures, for example, being able to implement SMART goals, so they're measurable and time specific and realistic and attainable. Continuing care, relapse prevention, and discharge planning with the patient and involving the significant other as well. The documentation, service coordination activities through the continuum of care. So being able to say, patient and I contacted agency X, we scheduled an appointment to have some dental work done or whatever the case may be. And then just apply placement, continued stay, or discharge criteria for each modality of the continuum of care. So being able to have certain markers at placement and then throughout the treatment and then at the conclusion of the treatment service. Hope that makes sense. I know I'm kind of going through this quickly, but I want to make sure we stay on track. Trying to see, Kate, can you tell me how many slides we're in? Trying to see, I don't see the number of slides listed anywhere for me. Do you know, I'll just kind of monitor where we're at as far as number of slides. I just don't quite see it.
I know there's a total of like 69 or 70 slides.
Yeah,
and
that's why I don't see a slide count on my screen, so I was just trying to make sure we were moving along.
Yeah, we're
anyway. Well, let's talk. Excuse me. Sorry about that. I just had a little coughing fit there. But maybe Kate can give me a slide count here as we're going. So let's talk a little bit about documentation as it relates to service coordination and the referral process. There are so many options to choose from, so many different ways to go about showing the work that you do. Let's talk a little bit about that process and what it looks like. And I'm sure that many of you have your own perspectives on documentation and what purpose it serves, but we know that if it's not documented, at least in our clinical world, it didn't happen. And sometimes this can be difficult to comprehend sometimes, especially if you're doing a lot of triage work or you're doing a lot of crisis intervention. These things can be difficult to document collaboratively or in real time, and sometimes things are lost. Documentation, really, as we know, this is review for many of you, but the documentation is the recording of all of the following and more. But it really is, if I'm making a referral, I want to make sure that many of these things, if not all of them, are included in that referral. And if I'm receiving a referral, if I would call the hospital up, if I would call University of Iowa Hospitals and Clinics, and they would say, my friend there would say, Steve, I have a referral for you for outpatient. He knew what I needed as far as documentation of the patient's stay to help me review that and approve them for admission to our outpatient program. So that I think is, let's see. Here we go. I'm getting a slide count. Thank you, Jude. And Kate, yes. I wonder why I can't see my own slide count. Maybe it's probably user error. Anyway, thank you for that. So we're making good time. I wanted to make sure that we didn't run out of time and that we had some time for questions at the end. But so if I'm making a referral or receiving a referral, these types of documents are absolutely vital. I would often ask for a current ASAM or a current transfer or discharge summary to really help me assess and understand why the patient was being referred to our agency and what level of care and if that was appropriate. I would also look at diagnoses, and I would look also at lab results perhaps, and or the most recent evaluation, substance abuse evaluation that was completed, or a mental health screener that was completed. There's a lot there. Again, sometimes less is more. I don't need the whole chart, but I need some specific pieces to help me either make a responsible, appropriate referral or receive and accept in a responsible, professional way an appropriate referral to my agency. The documentation, you want to really make sure that you demonstrate knowledge of accepted principles of the patient record management. So, these are just basics. These are review for many of you, but so you just want your records to be clear and concise and fall within the regulations, the governing body's regulations for documentation, and to make sure that, for example, that there's an appropriate identified DSM-5, ICD-10 diagnosis connected to your referral, for example, and that the documentation is done in an objective manner. So you're not saying, well, I think the patient needs to have a mental health evaluation completed because they just seem depressed a lot. Now that may be, that's very subjective, but you would want to be objective in your documentation for why you think a service is needed. Protect patient rights to privacy and confidentiality in the preparation and handling of records. Now, I mentioned this earlier with 42 CFR, Part 2, and the HIPAA regulations, but I think this is especially important when we are communicating this information, to a third party. If it's an internal referral or interagency referral, that's a little different. But when it's to a third party, very important that we have the proper protocol in place for obtaining consents to release information and releasing only the information that's necessary to make the referral. Again, this is I think probably very straightforward for many of you that have been practicing in the field, but it's important to review this, and if there are some newer clinicians in the audience, this is a good conversation to have with your colleagues and with your supervisor to make sure that you're not releasing information without the patient's consent. We'll talk a little bit about that if we have a chance to. And Maria's saying, oh, this is good. Yeah, she said well, you guys can see this. She had a session with a patient producing a recovery plan, and he stopped and told me, how can I talk about recovery when I have to cross my abuser every day in the street? The code of silences and often impunity are hard barriers to recovery, in my experience, and I cannot report rape or sexual assault. Yeah, that is definitely, yeah, no, that's definitely, that definitely can be a difficult dynamic to negotiate when we're talking about when to when to disclose and when to try and assist and advocate for your patient. What's in the best interest of the patient? Yeah, thanks for sharing that, Maria. Let's talk a little bit more about documentation. Record treatment and continuing care plans that are consistent with the agency's standards and comply with the administrative guidelines or protocols. So this may include things such as informed consent, document in a timely, clear, and concise manner, and recognize the importance of recording treatment and continuing care plans. These can be absolutely vital records to assist the patient in their referral process, or if you're receiving a referral, to help you know as the clinician or as the team where the patient's needs are. Also, to look at documentation, in the sense of recording, that you're essentially you record progress of the patient in relation to treatment goals or the healing goals and objectives. So, just simple things. We know this. You veteran clinicians know that we need to use appropriate clinical terminology. We need to show and evidence that the records are being reviewed and updated accordingly. Make sure you can read. I'm really glad that most documents now are typed, because my handwriting is pretty hard to read. So I'm really glad that for me, I was always glad that I could type my notes, even though I'm not a fast typer. It certainly beat trying to read my handwritten notes. And then just making sure that you're noting changes in that healing plan, noting changes in the treatment plan that you and the patient have worked on or that have been amended for any number of reasons. Preparing accurate and concise discharge summaries. Now, again, there are a lot of ways to get from A to B when creating a discharge summary. I've seen some that have been pages long and others that have been a paragraph. Sometimes, in some cases, less is more, but depending on the nature of the referral or the referral that I'm receiving or making, there should be at least mention of most of the components on this list. And oftentimes agencies will have, at least ours had a template that helped guide the clinician, especially if they were in the early stages of their career and learning. But that list right there is, I think, a good start to looking at preparing a discharge summary. If I'm making a referral, I need to keep the patient's interest in mind. I want to communicate the most concise and essential information to that referral source. It's really my duty and responsibility if I have the patient's best interest in mind. I hope that makes sense. Again, building on this idea of documentation in the referral process, we want to really look at being able to document treatment outcomes and being able to reference specific and accepted methods and measurement tools to do this. So just being able to gather and record outcomes, incorporate outcome measures during the treatment process, recognize that treatment and evaluation should occur simultaneously, and then just acknowledge and understand the importance of using measurable data to improve clinical practice. I do want to talk a little bit about community case management, and I think, and we'll talk or at least touch on this idea of case management. And I think, for myself, I always, case management can be resource heavy. Our agency would have case management components. They were usually grant supported or supported through some supplemental funding. But having viable, informed, competent case management in your treatment programs, for me, in our clinic, our nonprofit setting, was always a luxury that we often did not have. But community case management can be absolutely vital in maintaining continuity of care, reducing recidivism, patient relapse or recidivism, returning to treatment or primary care, and really can benefit the family and those closest to the identified patient, especially coming out of treatment or in an outpatient setting or continuing care setting. So just want to look at this strengths perspective to case management. There was some research done in the early, mid-90s. This idea that the case management's role really was to encourage patients to become more deeply involved in their own treatment. And this fits with this idea that the more I involve the patient in the decisions about their treatment process, the more likely they are to attach meaning and purpose to this. And I think that is a really important aspect to keep in mind when we talk about this strengths perspective as it applies to case management. Also, this research really touched on assisting patients in learning how to acquire and retain the resources that will support their recovery. For myself, when we had patients in a residential or detox setting, I would often say to them, your recovery really begins the day you complete your residential program, because then you're taking what you have and taking it into the community. And if I could assign a case manager, if I could assign a mentor or a peer recovery coach to them, I knew that their chances of being able to retain the information and apply the information that they'd been given would increase exponentially as they left their primary treatment care setting. I hope that makes sense as you're listening. But just looking at some of the principles about case management from this strengths-based perspective, it facilitates patients' identification of his or her strengths, abilities, and assets. And I think that is, again, this sense, creating this sense of efficacy, creating this sense of empowerment, also aligns very well with stages of change and motivational interviewing techniques that we see in a lot of different treatment modalities and approaches, both native and non-native. And also, this notion, this principle within case management concept is assisting patients in focusing goals, identifying alternatives, and locating resources by encouraging the patient to identify their own needs. I often would say to a patient, you're the expert on your own life. I'm here to assist and guide, but you need to let me know what you need so that we can work together to address those needs, instead of me telling them what they need, which is sort of my instinct, is to, especially if I have somebody that's really struggling and maybe not able to articulate or identify what their needs are, my tendency is to jump in and provide those, well, this is what you need. So I would encourage you, if you're a newer clinician, to try and resist that temptation to tell the patient what they need, and instead explore and continue to explore with them what they feel they need. Also, this, excuse me. Okay, I'm back. I think I just finally figured out how to mute that. So if I've been coughing on you guys, at least you're not getting any of this through the microphone. So let's look again at the strengths perspective to case management. Let's look at some more concepts. It serves really as this case manager can serve as a primary advocate for the patient and coordinates all relative services. I think in more recent years, we see this case manager, this case management role being fulfilled by behavioral health aides, or being fulfilled by peer recovery coaching or peer recovery support services. I think we'll see more of this in the years to come. But it encourages positive and proactive identification of resources in the patient's environment, including community agencies and social supports. This could be things as rudimentary and as basic as family and friends, but it could also be engagement in pro-social or pro-recovery services like the AA fellowship or Celebrate Recovery or Red Road or whatever there may be, that pathway to recovery, whatever presents. The case manager can serve as a conduit or a link or a bridge to said services. It works with the patient and the community to maximize the fidelity of the provider's perceptions and the patient's experiences. And I think this is really important too, because if I have a case manager or peer recovery coach that is coupled with the patient, they're really going to be able to oftentimes advocate and make sure that there is commitment on the part of not only the patient, but the services that they're engaging in to assure continued recovery and progress in their recovery lifestyle. So just wanted to touch just real briefly, there has been some research done on the effectiveness of case management in recent years. And I think there's more data and more research coming out about the importance and effectiveness of peer recovery coaching and behavioral health aides and these paraprofessionals that sort of walk between, being a part of the staff, but also being part of the recovery community. I think we're seeing this return and be the norm rather than the exception. Years ago, the addictions field or the substance abuse treatment field was made up almost exclusively of people in recovery. That was just sort of the norm. And that has really shifted over the years. In the last 30 years, there's a much greater mix of both recovery and non-recovering clinicians in the field, which I think is good in many ways, because it isn't such a myopic view on how one recovers, whereas with more non-recovering clinicians in the field, there's a broader view of what this looks like, and also what pathway you choose to recover. I hope that makes sense. But some of the research done the early part of the 2000s was really comparing results across case management-oriented programs. And this was difficult to do because the definition of what case management is really varies to a wide degree. And so there's really more studies that need to be done in order to really understand the true effectiveness of case management. Again, case management can be resource heavy, and many agencies aren't able to maintain a viable case management staff. And maybe some of you have experiences in that area where your agency or your team does have designated and committed case management component to it, and how that impacts treatment care or patient care I'd be interested to hear. There's just some different research site information links. If anyone's interested, they certainly can screenshot this, or probably some of you have are already familiar with, of course, the SAMHSA site and the NIDA site, and our HTC site is a great resource too. If you ever wanted to give me email or call, I'd be happy to talk with you more about some resources that are available out there. So we were able to talk a little bit about the referral process, service coordination, documentation, and then touched at least on the case management model, the strengths perspective, and really the understanding that there is a need for additional research on, I think, on case management, yes, but I'd also like to see there be some more research done, and there is some preliminary data on the effectiveness of peer recovery coaching in the recovery of patients afflicted with substance use disorders or recovering from substance use disorders. So I think that's kind of an overview of what we've done. I'm hoping that we can maybe field a few questions, and then we'll wrap it up for the day. So I want to thank everyone for attending and putting up with my coughing. I hope I didn't cough you right out of the room. But again, I just want to say thank you, and want to thank everyone for being here. And we'll open it up to questions now.
Thanks, Steve. Well, while we're waiting for questions, I'll just remind everyone that we always send out a follow-up email after our events, and with that, you will get the handouts attached, as well as a link to the recording. If you want to review this later, it will be on our YouTube channel, and we also will include the link to the survey in case you don't get directed to that right after we close. And so we would love to have you just let us know what you thought of today, and if it was helpful to you. So please take a few moments and do that. And we'll just give everybody a little bit more time in case there are any questions. But you may know that we offer this series every year. There are 12 sessions we do one per month, and so we offer this every year, and it's really to help you prepare for the licensure exam. And so watch for our emails announcing the ones each month in this series. And then we also have a few other series through through the ATTC. Our other one is American Indian and Alaska Native Behavioral Health webinar series. And then we also have mental health and prevention for Native American and Alaska Native programs. So watch for those emails. Let me know if you are not on our email list, and if you wanted to get those announcements, I'll make sure that you get on there. So oh, so you just asked what exam for licensure. So this series is actually developed to help alcohol and drug counselors prepare for their certification exam. So you can get certified to be an alcohol and drug counselor. Oh, Steve, sorry, I think you're still muted.
Okay, Joanne, that's a good question, and ICRC has standardized certification testing expectations. Each state has slightly different requirements for being certified as an addictions counselor. But the ESAS series and our face-to-face alcohol and drug certification exam prep courses are designed to help, specifically help Native Americans prepare for and sit and pass their certification exams so they can be credentialed and be in the field and be able to be part of the behavioral health workforce. That's the long answer to that question, Joanne.
Good. Well, it looks like that's all the questions we have for now. So, yeah, I just want to thank everyone again for joining us, and thank you so much, Steve, for teaching today and for braving your feeling cold.
I'm going to rest my voice. Well,
yeah.
Thanks for putting up with my coughing, everyone, and have a great rest of the week, and bless you all.
Thank you.